and warders of the Anishinaabe, Cree, Ojibwe Cree, Dakota, and Denisolan peoples, and on the national homeland of the Red River Métis. In northern Manitoba, we acknowledge the ancestral lands of the Inuit and gratefully acknowledge that our water is sourced from the Shoal Lake 40 First Nation. At CHI, we respect the spirit, intent, and language with the treaties that were made on these lands and acknowledge the harms and mistakes of the past and present. So our speakers are Dr. Eliseo Orrantia and Dr. Iain Lamb. Dr. Eliseo Orrantia is a long-time rural generalist physician in the Northern Ontario community of Marathon. He is in a full scope practice. He teaches all levels of healthcare learners and is involved in health system development. Dr. Orrantia engages in rural research as a tool for advocacy. Dr. Iain R. Lamb is a senior research associate at the Northern Ontario School of Medicine University. His research is focused on identifying strategies to improve healthcare access, elevate care standards, and enhance the recruitment and retention of healthcare staff in Northern Ontario's rural communities. I would like to again extend my gratitude to Dr. Orrantia and Dr. Lamb for taking their time to share their expertise and experience with us today. If we have any questions as participants, we can leave them in the chat box. I will pick them up, and then at the end of the presentation, Dr. Orrantia and Dr. Lamb will attend to them. And I hereby, it's now my pleasure to welcome Dr. Orrantia and Dr. Lamb to begin their presentation.
Thank you, Chinedu. I appreciate it, and thank you to the Center for Healthcare Innovations for having us today. And welcome to you all to the Rural Generalist Researcher presentation. So as Chinedu said, my name is Eliseo Orrantia, and I'm here with my co-presenter, Iain Lamb. And we're here to share some stories from the realm of rural research and to explore some of its many opportunities with you today. And just to say, as presenters, we don't have any conflicts of interest to declare at this time. Iain, if I could get the next slide, please. Thank you. So we are speaking to you today from the unceded lands of the Bitigong Nishnabek. Engagement in the process of reconciliation should have us all considering how we can improve the healthcare system to make it better serving for our Indigenous people. And given that many of our rural patients are Indigenous, I believe that with this presentation today and our discussion questions afterwards, that this may help us move in a small way in this direction. Next slide, please. So with our agenda today, we'd like to introduce ourselves a little bit more fully and then orient you to our region and community geographically, then orient you to our healthcare system. Then we'll dive into some of the rural research that we've involved in. And then finally, we'll talk about how we're leveraging that rural research to try to make a difference in our healthcare system. Now, given that we've been asked to help you understand opportunities in rural research, we're going to stay at a fairly superficial level with these studies, but we can always delve into them further in the question period afterwards. Next slide, please. So I think for folks to know, this slide is the only way that I get to be bigger than Iain's 6'5". Okay, so I'm a rural generalist, and as Chinedu has said, I have a broad scope of practice, and I teach with the Northern Ontario School of Medicine. And over the years, I've been involved in health system transformation work. And about 10 years ago, I came to the realization that I could do better at those tables than just bring forward the rural perspective and anecdote. What I needed was data. And unfortunately, for the issues that I wanted to champion, the data was fairly poor or non-existent. So at that time, I decided to commit, and I hired a summer student, and we started doing some research. And then over the years, I've been able to get grant monies, attract medical students on summer research scholarships, and also convince or coerce, as some might say, my colleagues, my local colleagues, into becoming involved with me in collaborating on rural research. And then at this point, our small group is really involved in doing rural research, as well as doing clinical medicine in our rural area. And we're really lucky that we now also have Iain as just a splendid support and a collaborator. So, I'll pass it over to you.
Perfect. Thanks, Ellie. So as mentioned, I'm a senior research associate at Nosson University. I'm originally from Kingston, Ontario. However, I completed my undergrad, my master's, and my PhD at the University of Guelph, graduating my PhD out of the Department of Human Health and Nutritional Sciences in 2019. I clearly didn't get enough of school because I'm currently enrolled in a second master's. That would be a Master's of Healthcare Administration out of the University of Regina. However, before I came to Marathon to join Ellie, I actually worked as a clinical trial coordinator at the Canadian Cancer Trials Group out of Queen's University. And while I really enjoyed the work, I found the red tape, the stringent protocols, and the regulations that kind of govern clinical trials to be really stifling to creative thinking. And I often felt my work was so niche and limited in scope that it left me yearning for a more dynamic and diverse role. And that ultimately motivated me to seek opportunities where I could ask bigger questions and contribute more to initiatives that had a broader impact on health and healthcare. And that ultimately led me to the current role I'm in, where I'd like to think we address just those things.
Yeah, thanks, Iain. So here's your neighbor to the east, Northern Ontario. It's our area of research interest, and it's a massive geography and a fairly small population of only over 800,000. What it does have is 106 Indigenous communities, and over 30 of those are fly-in access only. And in Northern Ontario, we have 35 rural hospitals north of the French River and about 5 urban ones. Next slide, please. So we're speaking to you today from the community, the rural community of Marathon on the North Shore of Lake Superior. As you can see, it's quite a drive from your urban center of Winnipeg. We have a population of 4,000 folks, and we serve 2 Indigenous communities nearby that have a total combined population of about 800. And our economy is mostly driven by a local gold mine. In our community, we presently have 8 physicians, and we're signed in on what's called the Rural Northern Physician Group Agreement, or RNPGA. This is a contract with the Ministry of Health in Ontario that has us providing primary care, ER services, and hospital services. And the interesting thing about this contract is that the government decides how many physician positions the rural community should have. And the physicians in 38 of our rural communities in Northern Ontario are on this contract. Next slide, please. So this is a photo of our Marathon Family Health Team. And a family health team is a government sponsored and financed group of interprofessionals that are comprised of folks such as nurses and dietitians and social workers that provide primary care to a local population. And most of the rural communities in Northern Ontario, beyond the smallest, would have a family health team. And the family health team in Marathon is co-located with our physician group, and we work very collaboratively together. Next slide, please. So in 2019, the healthcare system in Ontario went through this massive change. The 14 local health integration networks were dissolved, and in their place, the government put in 58 Ontario health teams that sort of cover the province geographically and are to provide integrated care to the population. Now, most of these health teams are early on in their development, but ultimately where the government wants to see them go is to become something akin to a regional health authority, where they would control the funding packet for all of the services in that locale. Now, these Ontario health teams are overseen and supervised by a new government agency called Ontario Health, and above them is the ministry on the org chart, anyways, is the Ministry of Health that sets the larger strategies and priorities for the Ontario healthcare system. There's been just a remarkable amount of change over the years in the Ontario healthcare system, but it's interesting to contemplate about certain things that are really slow to change. Next slide, please. I want you to meet Mike and Ange. These are two friends of mine that live in a community 2 hours to the east of us. Mike and Ange are a physician couple in life and in work, and they live in Wawa, and they're the only two physicians in Wawa where their physician complement should be, by their contract, 8 physicians. Since I started working in medicine 30 years ago in this community, there's been a constant challenge, and that has been the health human resource challenge that we have in Northern Ontario. Marathon is one of the lucky few communities that has the number of physicians that it needs in the rural north. The best estimate that we have, and this is from last year, was that we need about 110 rural physicians in the communities of Northern Ontario. Now, this is really the foundational healthcare system challenge, that of human resources, that has most engaged us in research. There's a lot of studies in the literature, well, there are at least some studies in the literature that talk about how to recruit physicians to rural communities. And from my perspective, it's not so much the recruitment that's the challenge, it's the retention. This is, I believe, more important and harder. There are a number of perks for the recruitment of physicians. In Ontario in particular, there's significant financial incentives. But it's estimated that the length of time that a physician will practice in rural Northern Ontario is on average 3 years. So I believe that improving physician retention in rural communities could have really great benefits and continuities and cost savings and just maintenance of historic knowledge, which is so important in developing the healthcare system. Next slide, please. I'd like you to meet Jelaine. Jelaine is a superstar medical student who's now a resident. She was the student that helped us carry out a qualitative study on why physicians leave their rural communities in Northern Ontario. And so what we did is we interviewed actually a number of physicians that had left in the previous 5 years and did a thematic analysis. And the findings really support that the importance of the physician partner and the importance that they have to be meeting their own personal and professional needs in the rural community they're in. There was also a lot of physician burnout that came up over and over again. And just to let you know, again, this study looked at folks that had left their communities prior to COVID. As well, rural being a low resource environment, the impact of the lack of opportunities for professional and personal goals and growth was a significant factor that we found. And finally, there was concern about the RNPGA contract and its lack of flexibility that didn't allow physicians to work part-time. So you're really selecting for a certain type of physician and not allowing much leeway there in how they could work. So next slide, please, Iain. Ghislaine's study can be considered one looking at the external factors that affect retention, but there's also factors internal to the physician group that can affect retention. You know, over the years, I've been privy to knowing a number of physician groups and communities that have had some real intra-professional challenges getting along with each other. This has, in some cases, culminated in physicians leaving their community, as well as even launching court cases against each other. Really disruptive, really disruptive. So our local physician group believes that our retention success here locally has much to do with recognizing the fact that we're an interdependent team of physicians, and that our internal governance and the way that we approach each other really matters. So thinking upon this further, we decided to test a model of rural physician teams. We wanted to question whether team climate, a construct created out of decision-making, communication, conflict resolution, then mediated through team efficacy, the belief that your team can successfully accomplish the tasks that is demanded of it, could positively predict team performance, team commitment, and intentions to stay. So we had this idea of this model to test, but this is where you need to recognize that rural generalists know a little bit about a lot of things, but in this, I was way out of my depth when it came to understanding the statistics needed to pull off this study. So just like I do with patients that I'm stuck on figuring out the diagnosis, and I send them to see a specialist, we went looking for an expert. And we found one. We found Teresa Klein, a professor emeritus from the University of Calgary, who's an expert in the statistics and the math to do the modeling and the validation that we wanted to do. So we ended up surveying 89 physicians in the 26 RNPGA communities that had 2 or more physicians in them, and also local observers of those groups of physicians. And what we found is that 84% of the physicians that we surveyed recognized that they functioned locally as a physician team. Unlike most physicians that you find in groups that are there because they're sharing overhead and front staff perhaps, but really little else of their function. So through mediated regression and generalized estimating equations, that's Teresa's magic, we found that the model was generally supported, even when external observers sort of ranked team performance, the statistics held. Now, the one place that we were challenged is when we incorporated the variables impacting retention that are known from the literature. Team efficacy did not predict intentions to stay above these other variables. However, it did mediate commitment to team, and commitment to team is a known element associated with decreased turnover. So, you know, the take home here is that it's important to recognize that the physician groups in Northern Ontario function as teams, and how they work together, graphic information and some more insight on the physicians of the RNPGA communities, which was published separately. And strikingly, you know, the smaller the rural community, the older the physician cohort in that community. So, Iain, I'm going to pass it on to you to talk about some of the other research that we've been involved in.
Perfect. Thanks, Ellie. So, as mentioned in previous slides, human health resources and healthcare remain a pressing issue, especially in rural health environments that have historically struggled with staffing, including obviously physician shortages. And I think the COVID-19 pandemic and its aftermath have brought this issue to the forefront. And these headlines, I think, really emphasize the scale and the impact of the rural staffing crisis in the health sector. And the fact of the matter is that until permanent solutions address the root causes of workforce shortages, rural healthcare systems increasingly rely on temporary doctors known as locums. And while locums help ensure that patients receive the necessary care, the reliance on temporary staffing is only a stopgap measure that really fails to address the underlying issues causing these shortages. However, as I mentioned, until we can find solutions to recruit and retain permanent physicians, rural health systems, again, remain heavily dependent on these locum temporary physicians. And problematically, approaches to recruit locums, especially to rural regions where they are most needed, are really poorly defined. This lack of clear recruitment strategy further complicates efforts to ensure adequate healthcare coverage in rural communities. So given the important role that locums play in our rural health system, an important question that we posed is, how can we improve locum recruitment to rural areas? And again, this question really aims to find out more effective strategies to ensure rural areas receive the healthcare coverage they so desperately need. So in an attempt to answer this question, we conducted a systematic literature review of locum recruitment methodologies used globally. And by examining various strategies from around the world, we really hoped to uncover best practices that could be adopted in rural healthcare environments to enhance locum recruitment. However, our findings really revealed that there are no consistently used locum recruitment methodologies, with different health systems employing different methods to recruit locums, and essentially a complete lack of standardized approach. And interestingly, what we also found was there was no indication of how well these various recruitment strategies actually worked at recruiting locum physicians. And this is problematic as taking a shotgun approach and asking health systems to implement all the identified strategies is completely unrealistic, especially in rural healthcare environments that are so often resource constrained. So as an extension of the study, we are now using recruitment approaches identified in the systematic review and consulting with healthcare leadership from across rural regions, as well as locums themselves, to find out which approaches really fall in this sweet spot of being most feasible for rural healthcare settings to adopt, but also desirable for locums. And so once we identify these approaches, our goal is to develop a locum recruitment framework specifically tailored for rural health environments. And ultimately, this framework will recommend feasible and effective strategies for locum recruitment with the aim of contributing to the sustainability of rural health systems. So staffing shortages have profound effects on all aspects of healthcare, and this is especially evident in obstetrical care services. As these recent headlines highlight, there is a growing trend of labor and delivery service closures across Canada, and rural Northern Ontario is no exception. Efforts to document the decline of obstetrical services in Northern Ontario were made in the past, but the most recent comprehensive study was conducted in 1999. Consequently, there has been a significant gap in understanding how these services have evolved or devolved over the following 2 decades. This lack of updated information left healthcare professionals, policymakers, and the communities themselves really without a clear picture of the current state of maternal care in the region. However, this gap was addressed by our 2020 paper published in, or it's actually a 2022 paper published in the Canadian Journal of Rural Medicine. And in this paper, we really examined trends, closures, and shifts in services to help provide an in-depth and up-to-date analysis of changes in obstetrical services in Northern Ontario over the past 20 years. And our findings revealed that the state of obstetrical care in rural Northern Ontario has significantly deteriorated since it was first assessed in 1999. Specifically, our research uncovered several alarming trends, including a significant increase in the number of hospitals in Northern Ontario no longer obstetric services, with 9 obstetric services actually closing in the intervening 20 years. And since our findings were first published, we can report a further 2 rural obstetrical services have since closed. Secondly, we found that rural hospitals in Northern Ontario that still provide obstetrical care have really limited the range of obstetric services that they offer. So for instance, some hospitals that used to offer C-sections perhaps no longer do so. And this reduction in service means that expectant mothers in the region face increased challenges in accessing comprehensive maternal care. And lastly, what we discovered is a decline of the number of healthcare providers, particularly physicians, actually practicing obstetrics in rural areas. And this shortage of providers exacerbates the challenges faced by expectant mothers as they have fewer healthcare providers to turn to for prenatal, labor and delivery, and postnatal care. And so taken together, it's evident that a maternity care desert is emerging in rural Northern Ontario, and this was not without its consequences, as closure means pregnant persons must travel longer and longer distances to access the care that they need. And this is particularly problematic as distance to care has been correlated with higher rates of complication, morbidity, mortality, and poor outcomes for newborns and their mothers. However, the question of why these services were closing remained largely unaddressed. While we presumed that Health Human Resources played an important role in the closures, a thorough examination of this and other potential causes was needed in order to effectively combat the growing maternity care desert in the rural north. And so to identify the why behind the closures of rural OBS program, we conducted a thematic analysis of qualitative interviews with physicians, nurses, and administrators who are working in rural Northern Ontario hospitals at the time their OBS services were discontinued. And our analysis revealed that 3 central pillars are really crucial for upholding rural obstetrical programs. And that is the provider competence and confidence in their obstetric skill set, adequate health human resources actually providing obstetrical care, and the collaborative support infrastructure such as policies, systems, networks, and institutions designed to support the delivery of obstetric services in rural areas. However, in rural obstetric services that had closed, we found that these pillars were largely eroded. With regard to competence and confidence, we found that physicians and nurses did not feel competent nor confident in providing obstetrical care, and this was primarily due to the lack of sufficient education and adequate training opportunities to stay current with latest practices. And this lack of professional development contributed to their decreased ability to deliver high-quality obstetric services and ultimately affected the sustainability of these programs in the rural regions that we interviewed. With regard to staffing shortages or health human resources, so again, staffing proved to be a significant issue as well. The inability to recruit and retain sufficient providers and support staff resulted in unsustainable workload for the remaining healthcare providers and ultimately led to service closures. And lastly, we found that collaborative support infrastructure was largely eroded in the obstetric programs that we interviewed. The support infrastructure, including policies, systems, and networks designed to facilitate obstetric care was weakened substantially. And this included inadequate communication channels, lack of resource sharing, insufficient institutional backing, all of which, again, ultimately hindered the effective delivery of obstetrical care. So having identified the causes of rural obstetric closure, we then focused on how best to address them. And to do this, we actually looked to Australia and British Columbia, two regions that face similar challenges with regards to closure of their rural obstetrical programs, but who have successfully implemented strategies to prevent further service attrition. And so again, conducting thematic analysis of interview with physicians, government officials, and educators from BC and Australia, ended up providing valuable insights for solutions preventing further OBS closure in the rural north. And combined with our data from interviews across Northern Ontario, we identified several recommendations to sustain rural obstetrics. So in order to bolster competence and confidence, we need to enhance education to improve labor and delivery education for medical learners and to ensure they are well prepared when they graduate to practice obstetrics. And secondly, we need to provide more funding and opportunities for continuing medical education, training, and upskilling in labor and delivery for rural healthcare providers to keep their skills current. With regards to health human resources, in order to bolster that pillar, we need to actively recruit healthcare professionals skilled in labor and delivery care to rural regions, as well as develop initiatives to support and retain healthcare professionals who offer labor and delivery services. And lastly, for collaborative support infrastructure, there's a need to establish cross-sector partnerships to support rural labor and delivery care and develop specific infrastructure, policies, and programs tailored to support rural OBS in Northern Ontario. And so while these findings will inevitably be published in an academic journal, effectively communicating them to the government bureaucrats and policymakers required a different tact. Recognizing this, we actually partnered with the Northern Policy Institute to develop an action framework white paper to help hopefully guide policymakers to implement effective solutions to sustain and improve obstetrical care in rural areas. And hopefully we'll have this action framework published by the end of June. And so now that we've discussed some of the studies we're conducting at a Marathon, the next question is how we can leverage our findings and these studies as a whole to make meaningful changes to enhance education, drive innovation, to create a stronger rural health system. And to address this, I'll pass it over to you, Ellie. You're on mute, just as a heads up.
Thank you. Thank you. Yeah, that would have been a very quiet presentation. So thanks, Iain. So we've done the rural studies, and now we've got these findings, this data, this information. How do we use these different threads to help weave a stronger, better fabric for our healthcare system? Now, Iain's already talked about one such approach, which is to educate and to inform, policymakers and government. We've also been working at advocating and innovating. And I want to share some examples of what we've been doing with you. So one thing that we've tried to do is really leverage media to spread the message of what we've found to inform and educate the general public. If the public is aware of the issues, then politicians pay attention. And those are the folks that we want paying good attention and putting their money where the issues are. And in our work in particularly obstetrics, we feel like we've been successful in that, and that we caught the attention of the right politicians and bureaucrats. Our work on rural physician workforce has helped me land as an expert and co-chair on a government committee that was tasked to review the complement number of physicians that was assigned to our rural communities. And this is the first time that was looked at in the last 20 years with the RNPGA contract. And what we were able to do is we were able to successfully add 30 new physician positions to the 38 RNPGA rural communities. And that's with a $10 million investment by the government. So the other way that we tried to advocate is through our local OHT. I'm on the governing committee, and I've used that as an opportunity to educate this group and to make health human resources, addressing the health human resources in our region, a strategic priority for our OHT. Next slide, please. The Ontario government has really recently funded a new organization. It's the Northern Maternal and Child Network. And our obstetrical work got us noticed, and there was an invitation that came out to me to join the steering committee. And this is another group that's provided an opportunity to share our research findings and to guide government spending on solutions that we found and developed. And, you know, we've got the ear of the deputy minister through this, this organization, which is great. Finally, in our research, what we heard was how dealing with infrequent but life-threatening emergencies in the ER and in obstetrics and rural obstetrics really was an impetus for some physicians to want to stop that scope of practice. They were just not feeling prepared, practiced, and up to date. So simulation education is one of the ways that you can practice a variety of crisis scenarios and develop skills and maintain those skills. Unfortunately, this teaching usually happens in large, expensive rural simulation labs. So to support rural physicians, we've developed a free online medical education resource called Practice. This website comprises of a library of rural-focused simulations in emergency medicine as well as in obstetrics. And it also provides all the tools and direction to support non-expert facilitators to provide simulation practice in low resource environments and rural environments for their healthcare teams. You know, we had planned this specifically for the rural generalist, but the medical students at the Northern Ontario School of Medicine got a hold of it, and now they're incorporating it in to help bolster their own education. You know, we're using research to help inform, to help advocate, and to help innovate. And it's all about producing a stronger health system. Iain, I'm going to pass it over to you for your perspectives.
Perfect. Yeah, thanks, Ellie. So kind of taking a step back, like I feel like I offer a bit of a unique perspective, having been involved in clinical research at an urban center and now working as a researcher in a rural environment. Again, offers a very unique perspective. And given the audience today, I'd be remiss if I didn't share how this perspective has highlighted several critical issues and challenges that are often overlooked in traditional research settings. So, for example, on the left here are some of the studies I was involved with at the Canadian Cancer Trials Group, and on the right are some of the inclusion-exclusion criteria for these studies. And you can see that, some of those include you need to be within an hour-and-a-half drive of a cancer care center. You need to have blood tests taken from a trial-approved lab. You need to get cancer restaging radiographs done every 6 weeks. And now imagine you live in a rural flying community and you're looking to participate in these trials. The geographic and logistic challenges make it nearly impossible for rural residents to meet these criteria. And this has really left me with the question of are rural realities represented in the research we run? Now, speaking to you as leaders in clinical research, I think there's a pressing need to be creative and reevaluate how clinical studies are designed and implemented to account for these role realities. This may involve reevaluating inclusion-exclusion criteria, accommodating to the unique challenges faced by rural participants. It could mean making participation in research more accessible to rural populations through telemedicine, decentralized clinical trials, mobile clinics, local partnerships. And importantly, it also involves actively including rural healthcare providers and patients in the planning and the design of clinical trials to ensure their needs and realities are considered. However, as a researcher, while rural realities present a challenge, I'd be further remiss if I didn't speak to the opportunities that rural research provides. And so these are kind of two big picture learnings or opportunities that I've identified through my time as a rural researcher. And to me, rural research offers a unique and rewarding opportunity for researchers to really engage with a broad spectrum of topics and challenges specific to rural communities, but that are translatable really anywhere else in the world. I think this field allows for researchers to become kind of versatile experts and developing skills across various disciplines as they tackle issues such as healthcare access, health equity, and community well-being in the areas in which they work. And I think the diverse nature of a rural generalist researcher kind of fosters innovation and creativity, as researchers are often required to devise novel solutions to address complex problems. And I think really by immersing oneself in the multifaceted landscape of rural life, researchers can make more meaningful contributions that drive significant positive changes and enhance the quality of life in rural areas and abroad. And I also think that the lack of resources in rural areas presents a unique opportunity for innovation and adaptability. Rural generalist researchers often face these limitations and are required to think creatively and develop resourceful solutions to complex problems. And again, this environment really fosters a diverse skill set and a comprehensive understanding of various issues, which will enable you to kind of address challenges holistically and maybe able to implement kind of changes that might not be possible in more resource-rich settings. And so the scarcity of resources, therefore, becomes a catalyst for developing versatile, resilient researchers who are well equipped to drive significant improvements in rural health and well-being, both, again, in rural areas. And I think those kind of skill sets are translatable anywhere. And with that, I'll hand it over to you, Ellie, for the last word.
Thanks, Iain. Yeah, so I'll end with a piece of advice, if I may, and then a plea. So my piece of advice is that if you're looking to engage in rural research and you're not yourself rurally based, I would really encourage you to reach out for the perspective of the rural generalist health care worker. They live in that world, and I think you may be surprised at the insights that they can provide you and the way that they can help you shape the questions that you're asking. And then my plea, and this is my action bias, I would really encourage you to consider taking that next step and use your research results to have a direct impact on the healthcare system. It can be an incredibly powerful tool, and let people outside of your scientific community know about your research and try to apply it as much as possible. Health systems everywhere, in particular rural ones, need improvement, and your research can be a really important part of making that change happen. And I want to thank you for your time and your attention. We are happy to engage with your questions now, and I'll pass it over to Chinadu to moderate. Thank you.
Thank you so much, Dr. Orrantia and Dr. Lamb. I don't know if, okay, Dr. Kelly has a question. Please go ahead, Dr. Kelly.
Hi, thanks. Sorry, I was going to turn my video on, but it looks like that's disabled. That's fine. So really, thanks for the great talk. So I'm a trialist here in Manitoba, and I do not rural based clinical trials in the space of pediatric oncology and pain. And so I wondered, besides, yes, involving and speaking with and learning from rural providers, are there any best practices or tools that trialists could, as they're going through their protocol, right? We want people to think of these things at the beginning, not at the end when they realize, oh no, there's no rural folks involved. So is there anything that you might recommend? I also lead a training platform, so I have an ear to the next generation of trialists, and I'd love to further your plea for them to include rural patients. And so I wondered if you had any tips for those who are writing clinical trial protocols, who are starting to think about how they're going to operationalize these things, and how they can maybe balance some of those, regulatory mandates, things like, oh, we need, MRI screens every 3 weeks, with what's actually feasible and practical for a rural or mixed setting, right? So yeah, just keen to hear if you have anything that you might recommend, or any place to go for more resources.
Iain, turning it over to you.
Yeah, no, I think that's a really good point, Lauren, and something that needs to be considered. And I think ultimately the answer is really incorporating that rural viewpoint, or at least making an active attempt to understand kind of rural barriers to participation in your trial. So kind of thinking intelligently about, places that are fly-in only, and how can those people really, are there opportunities to participate in trials? So really proactive working in addressing barriers to access is probably the most important thing that you can do. Granted, that can really only be done through or during the development of a clinical trial, as you're actually sitting there and writing up the protocol, the inclusion exclusion criteria, when you need to get whatever follow-up tests done to be performed. And so again, there's no best practices that I can recommend, other than ensuring that those voices are elevated and included when we start to think about the development of clinical trials. Yeah. I know that decentralization of clinical trials, as well as kind of the embrace of alternative modalities of care, so be it telemedicine or virtual medicine, potentially provide new opportunities for participation, but that really has to be baked into the protocol. And I think at the end of the day, it'd be nice to see flexibility for people who live in rural and remote communities, and if there's like kind of caveats that could be carved out in the protocols, so that people, again, living in these regions can be considered.
Yeah, and I just wanted to.
Sorry, Lauren, if I could just jump in here. Again, I'm not a trialist. I don't know your world. It's very foreign to me. But what I can tell you is that there's very few policies and programs and procedures that we have in our world, in the urban world, that are rural proof. So one of the things that you may want to start thinking of is incorporating the rural viewpoint early on in the development of your programs, to understand what Iain's talking about. What are these barriers? How can you make this rural proof? How can you facilitate the involvement of 1/5 of your population, if not more? And in particular, certain very much at-risk populations that may provide very different results to your studies. How do you incorporate them from early on and facilitate that? So rural proofing. Thank you.
I like that word, rural proofing. Yeah, I was going to point out, it's also similar to one of the projects that we've been thinking about with the North, right? A lot of these kids, as you mentioned, fly in care. That can be a huge challenge to have people come back for follow-up appointments, and seeing if we can arrange alternatives in the protocol for them to be seen in their own communities, and how to set up that kind of communication and data sharing becomes tricky. So if it's not collected in a auditable system, and we get audited, and how do we facilitate monitoring in these remote communities that don't necessarily have the same kind of infrastructure? It's a huge challenge, but I think as you mentioned, one where there's lots of possibility. And I think we need to think differently and all kind of advocate together for some flexibility in the clinical trial regulations also to support some of these things. Because I think, I do drug trials. I have to follow about 8,000 different rules. And it's really the rules also sometimes that create those barriers. And those are hard rules that we've had a really hard time pushing back against, and the rules that need to change, I think, in order to make some of these things possible. And so I just wondered if either of you have had any experience sort of advocating with government around like the food and drug regulations, or around how their modernization of clinical trials is ongoing right now. I just wondered if you'd had any sort of voices at that table.
So Lauren, I can answer from my perspective. I have not, but what I do know is ways in changing the rules. And the way to change the rule is to become a rule maker and to get yourself inserted at those tables. And what you can do is use your research as a lever to get yourself inserted. If you start bringing up this issue, right, and can show, the populations that you're not able to incorporate and what that might mean to your outcomes, and point to the barriers, you may end up at that table. They will need your perspective if they want to remain current and honest and true to the scientific method. So it's more on your shoulders. It's more on your shoulders, but it's also about taking that step to change the system.
And I think there's many shoulders make light work, right? I think if we can get lots of people at the table that have, I think what you said around who we're missing and what is the impact on that population and their care, we can preach equity and access all we want, but really until we're getting data that informs care in that population, we're still missing a huge mark. So I think that's a really good advocacy point around who are you missing and how does that affect their care? I think that's a really good lead. Thanks.
Systemic barriers, absolutely.
That's it from me. If anyone else has questions, feel free to chime in. Brendan, over to you.
Hey, thanks. I agree with everything Lauren has said. I think the access to diagnostic services in the rural areas is probably one of the larger challenges, particularly with laboratory diagnostics and those sorts of things. So that is it is a bit of a challenge for some. That now with the with applications that we're starting to see, mobile applications that are allowing for greater connectivity, and then of course this venue here. I mean, pre-pandemic we never heard of MS Teams. We never really utilized Zoom. Now we have more access to those sorts of things. And even the rural communities now are gaining greater access to satellite services and those sorts of things. So from a connection with the patient population, it is becoming a little more easier to connect remotely, but still a long way to go. But I just wanted to jump in to talk about that. I appreciate the complexities that you've presented and the challenges that are faced to meet this growing need, not only in your province but also in ours. Has there been any look at foreign trained, the impact of foreign trained physicians? I know we have quite a few foreign trained physicians that unfortunately, for one reason or another, are unable to practice because of limitations that have been put on by the colleges, and also nurse practitioners, and looking at the impact that they could potentially provide to these rural communities.
I was trying to get myself up and mute that, Brendan. Thank you for that comment. It's interesting, and I know I've been out west, and I've seen the numbers of foreign trained grads that tend to populate the rural hospitals and rural clinics. Ontario has not had that sort of influx. It's not leaned as heavily on the foreign trained grads, though I must say there's now a particular program of a more sort of quick entry into practice in Ontario that's being brought on by that sort of health human resource pressure, where foreign grads get it's just a number of months of evaluation. If they're able to pass that, then they get into a sponsored community where they're under sort of the loose guidance and observation of a physician in that community. And that's just, it's a very new program. So it's going to change the face of rural Northern Ontario healthcare and medicine. But there's no studies to that effect at this time. And again, we just don't have the numbers of foreign grads traditionally with us as has had the West. When it comes to nurse practitioners, it's a very interesting issue, and I don't know of much research in the rural realm on the nurse practitioner, but I can tell you, and again, unfortunately, I have to fall back to anecdote, which is not what we're here to talk about. But we have a nurse practitioner in our group, medicine. The challenge in incorporating nurse practitioners in the small rural communities is that usually they're at this point in time, they've mostly been focused on primary care. And if you start to take care of your population in the primary care sphere, then there's not the population for physicians to take on in primary care, where physicians have this multi-purpose of working primary care as well as in the hospital sector. And in a small community, you really want that animal that has multi-purpose. You want that multi-purpose tool. You know, and if you start slotting into a single function, it actually can prevent a more useful healthcare practitioner type from being in that same area. Now, that said, also got a great anecdote of a community just north of us, Geraldton, that whose hospital is innovating and really trying to take care of its emergency room, mostly based on nurse practitioner work there. So lots of things changing, lots of little attempts at success in that healthcare sphere in rural Northern Ontario, but not enough of a particular trend to study as of yet, though I'm sure that's going to be coming. Thanks for that question.
Thanks.
Thank you so much, Dr. Orrantia. Does anybody else have any question or any more questions before we end the session? Okay, I guess not. I want to extend my gratitude to you, Dr. Orrantia and Dr. Lam, for your expertise and experience that you have given us during this presentation. And I want to thank everyone for joining us. If you require a certificate of attendance for SOCRA CE, please just email us at info@chimd.ca. I want to thank everybody, and we'll communicate with you for the next SOCRA round. Thank you and bye.
Thanks, everyone. Bye now.
You're welcome.